Medicine at the National University of Singapore and Senior Consultant Infectious Disease Physician at the National University Health System. He's also the president of the Asia Pacific Society of Clinical Microbiology and Infection and the president of the prestigious International Society of Infectious Disease. He will be sharing with us about research in a pandemic, perils and pitfalls. I think once Prof. Wrongley signs off, Professor Tambyah will be joining us, and let's welcome Professor Tambyah. Prof. Wrongley, can you?
Okay.
Yeah, thank you.
Okay, I'll answer some of the questions later. Okay.
Okay, great.
Yeah.
Hi, good afternoon. Can you guys hear me?
Perfect.
Excellent. So I'm going to talk to you about research in a pandemic, and it's kind of a personal perspective. And I like the last few answers that Prof. Wrongley gave because they lead very nicely into my presentation. So I'm going to tell you a little bit about myself. I graduated from NUS, and then I decided to do my postgraduate studies in the US. And what happened was I wrote to 50 medical schools, and my wife wrote to 20 business schools. And the closest that we got was I got accepted in a place at one of the University of Chicago programs, and she got accepted at the University of Wisconsin. So after a couple of years, I transferred over to the University of Wisconsin, and that's how I met my mentor, Professor Dennis Mackey, over here. He's one of the leading authorities on device-associated infections. And so I began my research career doing work on catheter-associated urinary tract infections. Now, this person here is Tola, and she's the department secretary. Now, any graduate student will tell you the most important person in any program is the department secretary. So this is Dr. Mackey bringing her on for a beer at a scientific meeting after that. So anyway, I got some nice publications on catheter-associated urinary tract infections, and I turned it into an MD by research, which was a program that NUS used to offer at the time. And then I came back to Singapore in 1999, and I submitted a number of grants on catheter-associated urinary infections. And unfortunately, all my grants got rejected because nobody was interested in catheter UTI. And it wasn't a really very sexy topic at the time. But around that time, the avian flu started to emerge. It appeared in Hong Kong in 1997. And soon after that, there were cases in Indonesia and other parts of the world. And the dean asked me to try influenza research. And there's very little that I knew about influenza, but I went and tried to learn. I learned from people like Professor Raymond Lin and colleagues in the region. And again, as you know, influenza has been a number of pandemics over the years, the most notable being the 1918 influenza pandemic, which also affected Singapore, resulting in a doubling of mortality during the peak of the 1918 influenza pandemic. After 1918, however, the next pandemic was in 1957. And a lot of people don't recognize this, but the 1957 influenza pandemic was first recognized in Singapore by Professor Lim Kok An, who was the head of the then Department of Bacteriology at what was called the University of Malaya in Singapore. And I was privileged to actually have met Professor Lim. In fact, he taught me chess at the Tangling Community Center in the 1980s when I was a kid. And the way he discovered it was really pretty fascinating. So what happened was, he got a call from a friend of his who had attended the same course that he had been giving to our public health students. And he asked him, his friend asked him, would you like to visit Pulau Bukom to see some patients suspected having got influenza from the flu? Professor Lim didn't even know there was an outbreak in Hong Kong. So he went over to Pulau Bukom, found typical cases of influenza, took throat swabs, blood specimens, and he took them to chick embryos from Crawford Street at that time where there were hatcheries. And then he injected the chick embryos, and he managed to identify the virus, which behaved differently from all the other known influenza viruses. And he recognized that this was a new strain of influenza, never been reported. He sent it to the reference lab, to Professor McFarlane Burnett in Australia, and it was eventually discovered as a new influenza virus. The PICA will recognize no MTAs, no research collaboration agreements, just going over to Pulau Bukom, coming over to Singapore main island, injecting a bunch of chick embryos and then sending it over to Australia in an icebox, which is pretty amazing. Of course, he got a lot of credit for that, and he gave credit to his research team. So that was 1957. Professor Lim was really a character. He actually kept a diary, which his family put online, and you can actually read it if you want to. And it's very wise advice for a young budding clinician scientist. He said when he first joined the medical college, his uncle passed through Singapore on the way to the United States and gave him advice. He said the first was to be successful in research, choose a topic ignored by others and make it your own specialty. The second was find the best man in your field of study, go and work for him for a while, suck his brains dry, then go and work for his greatest rival and suck his brains dry, then you'll be ready to work on your own. I was not in a position to do quite what he recommended, but worked with Wilson Smith a little step in the right direction. And frankly, this is actually super good advice. So when I was asked to take on influenza, I invited Professor Fred Hayden, who is truly one of the world authority on influenza therapeutics. And he's a really nice person. So I invited him to Singapore. He came to Singapore as a Ministry of Health visiting expert, and he ran a seminar. And so I circulated this to NUS, NTU, to all the hospitals, to all the research groups in A-STAR. And I said, Professor Fred Hayden is going to be here. Would you like to share some of your research data? And it was amazing. All these people came out of the woodwork to share their data because they wanted Professor Hayden to hear about it. And the best part about it is at the end of the day, so I sat down with Professor Hayden and I asked him, okay, tell me which of this research is worth getting involved with and which of this I can dump. And he was very frank, he's American. So he said, this and this is good, the rest, forget it. So I very quickly identified who are the people to collaborate, who are the people to learn with, and who are the people to work to. One of the groups was the clinical trial group looking at therapy for H5N1 influenza. And so we got involved in this clinical trial of double dose versus single dose of influenza for H5N1 and other severe influenza. So even though we had no H5N1 in Singapore, we were enrolled as a study site. And ultimately, this was published in the British Medical Journal. This is funded by NIAID and Wellcome Trust, who do not pay for Wellcome Trust definitely does not pay for research in Singapore. We had to find our own funding, and the Singapore National Medical Research Council actually funded the Singapore part of the trial. I also learned how to get involved with industry, and so we worked together with Baxter on a clinical trial of a whole virus H5N1 vaccine derived from cell culture that eventually got licensed but hasn't quite been marketed, and it was published in the New England Journal of Medicine. However, it wasn't bird flu, but swine flu that eventually caused the next pandemic. And in 2009, some of you will recall, we had the H1N1 2009 pandemic, which hit the headlines in Singapore. There is very good epidemiology in Singapore done about this pandemic. And in particular, the Ministry of Health group found that unlike SARS, which was predominantly a hospital or healthcare acquired disease, the big clusters of infections actually occurred in a club. And this club was called the Butter Factory. I don't know if it's still around. It was set up by a bunch of lawyers. And essentially, there was a group of poly students, there was a group of army boys, and there was even a group of JC students with fake IDs who got infected with H1N1. And they were trying to link them all together. And then they realized that the problem was the bartender, because everybody goes to the bar. So this bartender was working while sick. So he was the super spreader who was spreading the virus to all these disparate groups of individuals. Now, some of you know that Singapore has a conscript army. So what this means is Monday to Friday, the guys are running up and down the hills. And on Saturday and Sunday, what do? They go clubbing. So a number of the early clusters of the H1N1 pandemic, there was a church, there was the club, and they were occurring in camps. So Maju camp, Tekong camp, Clementi camp. And you know, at the beginning, what the SAF did was they followed this containment strategy. So they identified a case and then they will quarantine the close contacts. And they did that for Maju camp, they did that for Tekong, they did that for Clementi. And after a while, the chief army medical officer, who's a friend of mine, called me up and he said, you know, at the rate we're going to end up quarantining the whole SAF. And we might as well shut down the army and open the door and let Al-Qaeda walk in. He said, this is crazy. Is there any alternative? And you know, a quarantine in Singapore is taken very seriously. They put a camera in your home or they put a wristband around your wrist. And you know, Singaporeans, they try and find a way out of things. So they used to put a photograph of themselves in front of the camera. So now what they do is they call you up, ask you to wave your left hand and ask you to wave your right hand and don't tell you which one is first. So you can't just put a video there. So this was a serious business. So I told the chief army medical officer, you know, in a nursing home, when we have an outbreak of influenza, we give chemoprophylaxis. We give, if one person gets influenza, we give all the other old people in the home Tamiflu. And it's not a great drug. It reduces the duration of symptoms by 1 day, but it seems to prevent outbreaks in nursing homes once they have started. So he said, sounds great. You know, the army budget, unlimited. I can give Tamiflu to everyone. Is it a safe drug? I said to him, well, you know, there's a 1 in 10,000 risk of neuropsychiatric side effects. And this has been documented in Singapore as well. Then he said, well, you know, it's not a secret. Singapore Armed Forces has 30,000 men. So if it's 1 in 10,000, then 3 of them are going to go crazy. And how do I know whether these 3 are going to be the 3 carrying a loaded submachine gun in front of a colonel? And I said, well, you know, we have no way of telling. We can't predict who's going to be that 1 in 10,000. He said, too dangerous. So what are we going to do? So I thought back again to the smallpox eradication effort. And you know, the original idea was to vaccinate the whole world. There was 3 billion people at the time, but it just didn't happen. It was just impossible. So what they did was they used the ring prophylaxis approach. In the 1960s and 70s, they offered $1,000 US dollars, which is a huge amount of money to somebody from a village in Africa or India. And they found every case, and then they ring prophylax. They gave vaccination to those around it, and it worked. We have no more smallpox for more than 30 years now. So I suggested we try and do this ring prophylaxis approach. Instead of giving every soldier in the army Tamiflu, we just give it to those around the contacts. And I have to admit, I'm a bit cynical. When it came to doing the analysis, I asked the MO who did the analysis, was this favorable to the drug? And he said, yes, it was. So I said, then let's send it to the New England Journal. And true enough, we got it accepted over there. So basically, there were 4 big outbreaks in the 4 camps. There was about 1,000 individuals who were found confirmed positive H1N1 2009. They came from different platoons, and they met each other during guard duty or in the canteen, so it wasn't really that predictable. And then we put in this intervention. And basically what it showed was just like Tamiflu reduces the duration of symptoms by 1 day, it reduced the outbreak in the SAF by about 1 day. So it would have ended on June 29th, instead of which it ended on June 28th. But the best part about it is we didn't have to quarantine anyone. So these soldiers could continue doing their 5BX, they're running there, touching the tree, coming back, running up and down hills, and all the things that soldiers like to do. So there was no minimal disruption. We did the whole genome sequencing just because we could. We got it included in the article. And essentially, we didn't have to prophylax 30,000 people. We only prophylaxed 800 people. And as a result of which, the side effects were relatively minimal. Some diarrhea, some headache, some nausea, a few allergic reactions. And so we showed that in the setting of a pandemic, ring chemoprophylaxis could work in semi-closed settings like the army. So again, you know, there's big difference between 2009 and 2020. And I think one of the big differences is that Margaret Chan, the WHO head, she declared in July, the outbreak was recognized in May, she declared in July, this cannot be stopped. She said there's still going to be a high-risk population, pregnant women, young people are going to die. But she said, you know, it's just impossible to stop. And so they switched to a mitigation strategy quite early on. In contrast, you know what's happened in the last few months. And I have to admit that I'm one of those who underestimated the new virus. Now, one of my roles, in addition to the university, is I have a concomitant appointment. I had a concomitant appointment at the National Center for Infectious Disease. And what we did was we gave small travel fellowships to scientists going to major research institutes overseas. So we gave an award at the end of December to a scientist from A-Star to go to the Wuhan Institute of Virology, Chinese Academy of Sciences. And this lady, she wrote to me at the end of January, and she said, there's a recent virus going all over Wuhan, spreading over the whole of China. I have to cancel my flight. The hotel has reimbursed me, but the budget airline Scoot doesn't want to refund my ticket. Can I still reimburse it? And to my eternal shame, I wrote to her. I said, we should try and reimburse if she can provide documentation she was actually told not to go. If she's just scared of getting pneumonia, then we should not reimburse her. And of course, you all know that now there are 40 million people, the city shut down, 40 over million people all over the world have been infected with this virus. And so it's clearly not something to be underestimated. So what are the research questions that we have? These were some of the 3 key research questions that we identified at the beginning of the outbreak, very early on in the NUS translational research program. Questions were, how do people get infected with the virus? How do we treat people with the infection? And do we have long-lasting immunity to the virus? In other words, is there any point in developing a vaccine? So this is, I'm a clinician. Again, I look after patients, but I am heavily involved in research. And this is a patient we looked after. 45-year-old man, cancer of the thyroid, came to the emergency department with fever and some sore throat, running nose. Lungs were clear. He was sent home. His chest X-ray showed minimal changes. He worked in a church. He came back a few days later. His X-ray had gotten worse. He was admitted to the isolation ward. This time he got a swab, which was positive for the SARS-CoV. He developed some mild dyspnea. He was treated with an anti-HIV drug, lopinavir, ritonavir, as well as antibiotics. He actually responded the very next day, and I told him, wait, that's way too fast for the drug. It's probably the natural history of the disease. And he stayed in hospital for a few days until he was PCR negative and he was discharged. What is significant, though, is that he was identified as part of one of the early clusters of COVID disease. And this was associated with people connected with one of the churches in Singapore. And this was very thoroughly investigated by the MOH group and published in The Lancet. And what was very striking is, you see here, there were 2 individuals from China who were not church members, attended the service, left immediately after the service, had no contact, didn't even share the same air supply with anyone. But what they did was they occupied the same seat as an individual who went on to spread the virus to other people. So the Ministry of Health group managed to track down 191 members of the church, screened them all for symptoms, tested them, and none of them tested positive for the virus. So this virus is airborne. It's probably the world's least effective airborne transmitted virus. But there is this question about the seat and whether the virus can be transmitted along surfaces. Now, why do people persist in believing that the virus is airborne? And this actually dates back from the time of Hippocrates. For 1500 years, people believed in this miasma theory. So this is cholera coming up as a virus, as a bacteria spreading through the air, malaria, bad air. And this has been fueled by papers such as this one, where the Van Dormalen paper, which was published in the New England Journal of Medicine, where they showed that aerosol virus could remain airborne for 3 hours after dissemination. At significant titers, you got viable virus. But what I tell my students is you always need to read the fine print. And if you read the fine print, you realize that they used a high-powered nebulizer, a high concentration of the virus, and they suspended it in a chamber, which is used to test for bioterrorism agents. So it's clearly very different from real life. In contrast, in real life at Singapore's National Center for Infectious Diseases, in a room of a patient with actual viral infection, they found the virus all over the surfaces, on the bed, on the locker, on the chair, on the sink, in the toilet, even in the toilet bowl, but they couldn't find the virus in the air. This is a negative pressure room, so it's quite interesting there. So this group from the University of Nebraska, they are strong believers in airborne virus, and in fact, they have been responsible for helping to build the negative pressure rooms at our NCID. Even though they found viral RNA in the air, they couldn't find culturable virus. So finally, a group from University of Florida found viable virus in the air. But this is very unusual. There were 2 patients. They had a high volume sampler. And one of these patients was not shedding virus anymore. So this patient was negative for the virus, but they still found viable virus in the air. So we're not sure where the virus came from. So you may have seen that 239 scientists wrote an open letter to the WHO talking about airborne transmission. Now, I don't know if this is true, but people ask me why 239? And I was actually asked to sign the letter, and I refused to sign it because I didn't believe in aerosol transmission. So maybe it was supposed to be 240, it became 239, I don't know. So airborne transmission has got implications for PPE. If a virus is airborne, you need an N95 mask. So during SARS, N95 respirators were widely available. In fact, we even had a bank robber using an N95 respirator to rob a bank, but it was so uncomfortable, he had to put it on his head, he got caught by the security camera. Fortunately, during H1N1, we realized that the virus is spread primarily by droplets. And so surgical masks now dominate. Even bank robbers are now using surgical masks and not N95 masks. So this is still a huge point of discussion in the WHO amongst various experts, but there's interesting data just published out of Taiwan, where they showed what has happened with COVID, with all the restrictions, with the lockdowns. Even though Taiwan had no lockdowns, there's a lot of mask using and things like that. Influenza has disappeared. There's been no influenza in Taiwan. In fact, there's been hardly any influenza anywhere in the world since June, even in places which have influenza seasons like South America, South Africa, and Australia. But in contrast, varicella, which is an airborne virus, is still the same. So there's been no difference in varicella, but no influenza. Big mystery. Don't know what the answer is. You know what I think. So what we did was we ran a research project. We got funding from a donor who allowed us to buy the required machines. We set this up in rooms of patients with proven COVID disease. We actually had an innovative approach. We used a strainer so that we could make sure that this virus really was through the virus and not through somebody touching a surface. And we've got some interesting preliminary data that we're still in the process of analyzing. Second question, how do we treat these patients? So in collaboration with Professor Justin Chu, we ran drug screens. We used the virus, we used the pseudovirus, and tried to run it against various different drugs, and some of that has been explored. We also got involved in clinical trials run by the National Institutes of Health in collaboration with NCID and Associate Professor David Lai and his group. Now, the big thing in Singapore has been that the epidemic has occurred in the dormitories, and these have been huge. This is numbers in imported cases in the 50s, the 60s, the dormitories up to 1,000 cases a day. The attack rate has been extraordinarily high. In this one published paper, there were 5,900 foreign workers, of which 1,800 were symptomatic, and 69% of them were found to be positive, which is like the world's highest attack rate reported. Unfortunately, as they were trying to protect the general community, screening amongst the dorm workers was relatively limited. So this is what we call the Diamond Princess approach. The dorms were locked down, the virus spread amongst them, but the general population was not exposed to dorm workers, and the rates in the population outside the dormitory were kept low. Now, thinking back to what we did with 2009 H1N1, we felt that, rather than leave these guys as sitting ducks, we should do a prophylaxis study. So we ran a prophylaxis study with 4 different arms, and again, the results are being analyzed as we speak. So question is, the last question is, do we develop long-lasting immunity to COVID-19? And again, this is a study done in collaboration with Duke NUS, where we got individuals who had recovered from COVID-19, together with individuals who recovered from SARS 17 years ago. And this is the nice thing about this outbreak. Remember, SARS affected primarily healthcare workers. So I got doctors and nurses calling me up when COVID-19 appeared, offering to donate their blood for us to study them, to try and understand the virus better. And what we found is very striking, that even 17 years after SARS, SARS-infected individuals still had T-cell immunity, which could be stimulated, which could destroy the COVID virus. So this gives us great hope that a vaccine may work. So answers, do people get infected with SARS-CoV? Not by air, probably by contact and possibly droplet, but again, this is controversial. How do we treat patients with COVID? Dexamethasone looks like it works. The antivirals seem to be relatively limited. Can anything be used to prevent infection? Hopefully. Do we have long-lasting immunity? Probably yes. Why don't children get disease? We don't know. So pandemics come and go. And this is one of the ironies of life, is that I told you nobody was interested in UTI. And they were all talking about flu and SARS and COVID. But a few years ago, all of a sudden UTI became interesting. And one of the PhD students actually wanted to switch supervisors. So I said to him, what's your skill, special skill? And he has the ability to catheterize a mouse. He's a vet. And so we actually got a chance to take these UTI projects into animals. It was a real difficult job. And ultimately, after lots of blood, sweat, tears, and pig urine and mouse urine, Kera graduated. He's the last PhD student I've graduated his PhD, got some nice publications, and we're moving the UTI field forward. So my personal views, always choose your graduate school based on what your spouse wants, okay? Second, follow your interest, be prepared to be flexible, as the previous speaker mentioned. Science wins in the end, and have fun in the process. Thank you very much.
Thank you, Paul. Wow, very exciting and timely research on pandemics, including the current COVID pandemic. And I think your advice to follow where your spouse goes is very interesting. Okay, so there are 1 raised hands and 2 questions. Maybe the Varuni, would you like to unmute yourself and ask your question? Or you prefer not to? Or maybe what we'll do is we'll answer the Q&A first. There are a few reports of Martians in the virus? Is there mutations in the I think it's mutations in the virus.
Mutations, yeah.
Yeah. Are these reports, if these reports are true, then will a vaccine work?
Yeah, that's a very good question. And some of you may know that I have an interest in the D614G mutation, which appears to increase infectivity, but potentially may actually reduce the virulence. The interesting thing about this virus is that the mutation rate seems to be relatively low, in that if you look at the strains of the virus, and there are thousands of genomes that have been published in the GIS-AID website, you can see that the rate of mutation seems to be very low. It seems to be very well adapted to the human host. So what we are seeing is serial passage of a virus through multiple human hosts with relatively little pressure to result in substantial mutations. And so these are small mutations, and there's no indication that the vaccine is not going to work. In other words, the vaccine is likely to work because these mutations are not, at least so far, are significant. Over.
Okay, are there any more other questions? Maybe you can share with the rest of the audience. Is it easy for a graduate student to do such a pandemic kind of research?
Okay, it's super difficult to do this kind of research, but on the other hand, it's super rewarding. I mean, it's difficult because, you know, the safety issues when you're dealing with a new virus are very challenging. So you need to have the training. And in fact, this is one of the things we just had a conversation yesterday about that, is we want to prepare people long before the pandemic strikes. So we want to have people who are working on BSL-3 pathogens. So you are trained, you know, you don't have to train on the, and it's something that has to come naturally to you. So that if something you do day in, day out, you should have no difficulty just adapting. So say you've been working on Ebola every day for the last 10 years, you know, to go from Ebola to the next coronavirus is not a big deal. So we are trying to build up this capacity. There are BSL-3 labs in Singapore, and there is opportunities for people who are willing to work at it. And you know, it's pretty safe. My mom always says, you know, why do you work in infectious disease? Don't you think it's dangerous? I said to her, it's a lot more dangerous if you don't know what you're dealing with. You know, by the time they tell me I'm working on this sample and it's got infectious disease, you can take all the necessary precautions. So I wouldn't be too paranoid about that. There's a question in the chat about, do you recommend the use of N95 masks? And the answer is I do, especially when there's aerosol generating procedures. But in terms of routine patient care, that's one of the things I'm really happy about, is that during SARS, we had to wear N95 masks all over the hospital. And you know, I found it really hard to breathe. I think it reduces your minute ventilation, increases CO2 narcosis, not a good situation to be in. But this time, we wear medical or surgical masks all around the hospital. And we only wear N95 masks when we're in close contact with confirmed patients or when we're doing aerosol generating procedures. So the answer is I recommend N95 masks in certain specific conditions. Over.
Okay, thank you very much. A very exciting talk, and I think we learned a lot from you. Thank you very much. Okay.